Good morning, ladies and gentlemen. Welcome to Grand Rounds. Just want to mention that next week we're going to have one of our own faculty, Barbara Stanley, present, and the topic is Zero Suicide Initiative, Mission Impossible, ? A couple of announcements on the Good News NOGA side. Chris Kellendonk received a 2-year grant for an R21 from the NIMH on thalamoprefrontal interactions in cognition, cortical layer. And Sylvia Bernardi received a K08 award from the NIMH to work on neural mechanisms and for the genesis of conceptual information. So congratulations to them. Also, I just wanted to announce something that's, I think, up on the screens, or may have come in email, is that tomorrow, so I think you know, about a year ago, the medical school established a new department of medical humanities. Medical humanities? Ethics and Medical Humanities that Rita Sharon is the chair of. And we've been talking with Rita about things that we might do collaboratively, and one of them is a seminar series called Voices in Mental Illness. And tomorrow we'll have one of those. It'll be at 10 o'clock in the multipurpose room, and the speaker will be Molly McCloskey. So Molly is a acclaimed writer who's written fiction, novels, and so forth. But she also wrote a book about her brother who suffered from schizophrenia and, as all too often is the case, really didn't fare too well in terms of his treatment, his outcome, his homelessness, and so forth. So she wrote a book called Circles Around the Sun, In Search of a Lost Brother. So that'll be tomorrow at 10 o'clock. Well, it's a pleasure to have one of our own faculty, or at least neighboring faculty in Neurological Institute, speak today, Adam Brickman. So Adam is a native of Toronto, Canada. I couldn't have picked that up from your accent. And he then went to Oberlin for his undergraduate degree, and then CUNY for his PhD in psychology, neuropsychology, and then did a series of internships at Mount Sinai and Brown, postdoctoral fellowships at Columbia, and landed in the Neurologic Institute as part of the Taub and Sergievsky centers, focusing on aging and Alzheimer's disease. And he's had a very productive and successful engagement with that powerhouse program, which really overlaps with our faculty and our interests, and has focused specifically on the identification of neural systems, using imaging and neuropsychological assessment to characterize brain aging and the impact of neurodegenerative disease, with a particular focus on cerebrovascular pathology. So it's a pleasure to have him talk to us about this topic, which is becoming more and more interesting for those of us who are growing older. So please welcome Adam Brickman.
Thanks so much. It's a real pleasure to be here. I've been at Columbia for a few years now. I think this is the first time I've spoken to the Department of Psychiatry, so it's a real treat. I grew up in a psychiatry department, so you guys have a very familiar vibe to me. So today I'll be talking about Alzheimer's disease, risk factors, biomarkers, and something that I've been obsessed with over the past several years, white matter hyperintensities. These are my disclosures. And so what will I be discussing? Just Alzheimer's disease in general, the current zeitgeist models of pathogenesis, some of the caveats in those models, vascular risk factors, white matter hyperintensities and their role in Alzheimer's disease, the interaction or the potential interaction of cerebrovascular disease and Alzheimer's disease pathologies, and we're focusing a lot on amyloid and tau. If we have time, I want to just mention a single biomarker that we've developed that combines both vascular and neurodegenerative elements appreciated on MRI scanning. And then I want to talk about some of the work that's sort of in the hopper. So I have the requisite public health impact slide in all my talks, and Alzheimer's disease is a problem. I think everyone's aware of that. It's a problem for older people. As you get older, it becomes more of a problem, and it seems to have a predilection for different racial and ethnic groups, and that's certainly one of the focuses in our work, understanding racial and ethnic disparities. By the year 2050, we project that almost 14 million Americans will have dementia or Alzheimer's disease. And of course, if we don't do anything about it, this will be a real drain on people's lives and the healthcare system in general. Yes?
Is 14 million AD or all?
Right. Well, we're going to talk about the question was, is the 14 million AD or all dementias? So we'll talk a little bit about definitional aspects of what is dementia and what is Alzheimer's disease. This figure is referring to dementia in general, and we think that the majority of dementia cases are caused by Alzheimer's disease, but I think that the question of what exactly is Alzheimer's disease is really quite relevant, and I'll get into that a little bit. So let's talk about Alzheimer's disease diagnosis through the ages. So this was the first patient with Alzheimer's disease, if you will. She was examined by Dr. Alzheimer, and he saw a clinical syndrome, which was described at the time, but he saw a 51-year-old woman, so quite young. She had reduced comprehension, memory impairment, aphasia, disorientation. She had prominent neuropsychiatric symptoms. And she was diagnosed clinically with presenile dementia. So Alzheimer's big contribution, Dr. Alzheimer's big contribution, is really trying to correlate the neuropathology or the histology of this syndrome with what he saw under the microscope, and the histology techniques were really becoming quite common, used in labs back then. So what he found were these fibrils, which we later found out are these neurofibrillary tangles, and these miliary foci with peculiar substance, which we now call senile plaques. What I always point out, although Alzheimer himself didn't point out, is that the attending pathologist noticed prominent small vessel disease in this particular patient. She was 51, and he noted it in his pathological note, but Alzheimer himself didn't think that was so interesting. And so I think the consensus, at least in his lab, was that there's a new disease to classify here, that there are these strange tangle and plaque formations that seem to be present in this woman with presenile dementia. And Emil Kraepelin, who is one of my heroes, and I assume many in the audience as well, coined the term Alzheimer's disease in his classic psychiatric textbook. And it was, I think, as I understand it, a bit of a publicity thing. He was really trying to get recognition for his lab and slapping names on things associated with his lab. Since then, that kind of thing doesn't happen anymore. So Alzheimer's disease, around the turn of last century was initially characterized by Alzheimer himself, and this was considered a presenile dementia, which is really quite uncommon. But it wasn't until the late 70s, and maybe these folks are familiar to some of the people in the audience here, where it was really Bob Katzman who put out this article. Bob was at Albert Einstein. He's a pretty famous pathologist. And what he found was that, when they started looking at older adults, not the presenile cases, but older adults with dementia, they too had these plaques and tangles. And what Bob really concluded, this was probably one of the most cited editorials in our field, that the prevalence and malignancy of Alzheimer's disease is really much more profound than we had appreciated, that these cases of late onset dementia were really the same pathological substrate as the early onset presenile dementia. And when you consider all the older adults with dementia, it's a real public health problem. And so he put this out, and that really changed the field, and this ushered us into the modern day of Alzheimer's research. This is a major public health crisis. And so this led to some consensus conferences and ideas of different centers coming together and coming up with standardized ways of assessing and diagnosing Alzheimer's disease. And the one that's even used today very commonly is these McCann criteria. So in 1984, the clinical diagnosis of Alzheimer's disease was put forth as a probabilistic diagnosis. And it's probabilistic because those plaques and tangles at the time we couldn't measure in vivo. We could only guess whether someone had plaques and tangles. So a diagnosis of probable AD was assigned when there was a dementia syndrome, and any other obvious rule out any other obvious potential cause of dementia was ruled out, a massive stroke or vitamin B12 deficiency or other neurodegenerative dementias like Parkinson's disease, et cetera, were ruled out, we would diagnose the syndrome of probable Alzheimer's disease. Of course, there's possible Alzheimer's disease where there's a dementia syndrome and there's some question about onset and course and may be present in the context of other causes of dementia. But we assigned probable or possible Alzheimer's disease when we still thought that AD was playing a big course in the clinical syndrome, or a big role in the clinical syndrome, but it might be mixed with other different pathologies. And yeah.
That's not our neurosurgeon guy.
That's Guy McCann's father. Guy McCann, there's a Guy McCann at Columbia University, he's a neurosurgeon, and he has the same name as his father, who's the lead author of this paper, was the chair of neurology at Hopkins for many years. So yes, there's some Columbia connection here too. So the diagnosis of definite Alzheimer's disease was diagnosed historically only when there was the clinical diagnosis of probable AD and the autopsy confirmation or biopsy in very rare cases of these plaques and tangles. And so this is overall what we still use clinically, kind of, right? So people come in, they get a neuropsychological evaluation, they get a psychiatric and a neurological evaluation, and we say, okay, your syndrome looks like it's Alzheimer's disease, we bet that that's what you have, right? But that's changed a lot, and this is what I just said. So while all this was happening, the amyloid cascade hypothesis really came into play as the predominant hypothesis of the pathogenesis of AD. And it goes something like this. I would say all the arrows are magic unicorns because we don't understand how one leads to the next. But this is the hypothesis, right? That there's some change in A-beta or beta amyloid metabolism that somehow causes these fibrils to oligomerize and deposit plaques extracellularly. And these somehow, the plaques, somehow magically cause abnormal distribution of tau pathology, which is intracellular, and the tau protein to become hyperphosphorylized. And then that causes the aggregation of tau pathology, and that propagates along the neurons, leading to neurodegeneration, and finally the dementia syndrome, which is, we think, caused by the neurodegenerative and tangle pathology predominantly. So anyone who's gone to an Alzheimer's meeting has seen some version of this figure, and this is the famous Cliff-Jack curves. And what Cliff did was tell us about the staging and the ordering of the biomarkers or the biological and clinical changes that we see in Alzheimer's disease. So let me unpack this for you a little bit. So on the y-axis, we have some level of biological or clinical change, and on the x-axis, we have some clinical staging going from cognitively normal to mild cognitive impairment to dementia. And what we see, or what we hypothesize, these are hypothetical curves, is that A-beta pathology begins to increase well before we see any clinical symptomatology. And that's followed by tau-mediated neuronal injury and dysfunction, brain structure abnormalities, memory and other cognitive dysfunction, and finally, the clinical syndrome of Alzheimer's disease. And what's been exciting about me growing up in this field in the last 15 or 20 years, whatever it's been, is that rather than relying on these probabilistic and syndromal definitions of AD, now we have biological markers that can operationally define each one of these biological and clinical stages, right? And so what's now FDA approved, we have amyloid PET scans that can measure amyloid accumulation. We can also appreciate amyloid protein in the CSF and get a sense of whether someone has amyloid in their brain. Now we have tau PET scan, not FDA approved yet, but it seems to work pretty well. So we can measure tau pathology in the brain. We have, of course, exquisite MRI, neuroimaging to quantify hippocampal entorhinal cortex and cortical atrophy. We have neuropsychological testing to operationally define the cognitive symptoms of the disease. And finally, the clinical exam to sort of capture the whole dementia syndrome.
Adam?
Yeah.
Can you go back to the last slide?
Sure.
So is it accurate to say that from when Alzheimer made his histopathological observations till Davies and Katzmann, there was really little additional progress in understanding the neurobiology?
Yeah, I think that's fair to say, yeah.
So then, in your schematic progression, so Davies' original finding was a deterioration of cholinergic neurons in the nucleus basalis.
Yeah.
Where does that fit in?
Yeah, so into the sort of acetylcholine hypothesis of Alzheimer's disease. So that was, it doesn't fit so much with the amyloid and tau cascade hypothesis, but the idea, I think, in the late 70s, early 80s, Ken Davis and Rich Mose and those guys at Stanford at the time, where there are these sort of predominant neurotransmitter hypotheses of neurodegenerative diseases. Parkinson's disease is too little dopamine. Schizophrenia is too much dopamine, Alzheimer's disease is too little acetylcholine, and to a certain extent, that's true. There is a cholinergic deficit in Alzheimer's disease. I'm not sure exactly how it fits in with the plaque centangles, but the only approved FDA medications for Alzheimer's disease, or at least two of them, are acetylcholinesterase inhibitors, so that still is meaningful.
There must be a way to integrate it, because, his finding wasn't a pharmacologic finding. It was a loss of cholinergic neurons
in the nucleus basalis manner. Yeah. So I again, I don't think that fits in with the amyloid hypothesis per se, but it could be the result of neurodegenerative changes. So sort of a downstream or end stage result of Alzheimer's disease. It's probably true that if any one of us in the room took acetylcholinesterase inhibitors, our memory would improve as well. So it's probably not that specific for AD per se. Okay, and so now that we've sort of been ushered into the age of biomarkers, we can now use, instead of the rule-out diagnostic scheme, the probabilistic scheme that Guy McCann and colleagues put out, we can use a biomarker-based approach. And this happened in 2011. The new diagnostic criteria for Alzheimer's disease, there are 3 diagnostic criteria proposed. One was preclinical Alzheimer's disease, and that was having biomarker evidence of amyloid pathology, maybe some tau pathology, and maybe some brain structure abnormalities. But if you have those biological changes, then you'd meet the criteria for preclinical AD. We had mild cognitive impairment due to Alzheimer's disease, and that was evidence of biomarker positivity for AD, and some degree of cognitive change. And then the third diagnostic group was Alzheimer's disease per se, which is evidence of biological markers of AD along with the clinical syndrome. And so we went from this rule-out diagnosis to this rule-in diagnosis, that there were 3 influential papers put out in Alzheimer's and dementia. If you're wondering why the journal Alzheimer's and Dementia has such a high impact factor, it's because they published these 3 papers and they get cited a ton. They include some of our friends here at Columbia. And these diagnostic criteria really started thinking about biological changes as a diagnostic avenue for Alzheimer's disease. So that was 7 years ago. Now today, 8 years ago, Cliff Jack and colleagues have put out a new NIA research framework, which now proposes new diagnostic criteria. Let me go through this with you. So the way we diagnose Alzheimer's disease in the research context now is ask the question, do you have amyloid pathology in your brain, either by CSF or PET scanning? If you don't, then you don't have Alzheimer's disease. If you do, we ask the question, do you have tau pathology? If you don't have tau pathology, then you have Alzheimer's pathological changes or preclinical Alzheimer's disease. And if you do, you have frank Alzheimer's disease. So what's interesting about this, there's absolutely no consideration of the clinical symptomatology in the new diagnostic scheme for Alzheimer's disease. It's entirely biomarker-based approach, right? So we'll talk about why that might be a problem. Of course, if you meet criteria, we might want to do some staging afterwards by calling you unimpaired or mild cognitive impairment or dementia. So what are some of the caveats of this? I've been very vocally critical about this. I'm trying to tone it down, but I'll get into it a little bit. So first of all, 30% of older adults who are non-demented, who don't have any clinical symptoms, have amyloid deposition detected with PET or at autopsy. We've known this from autopsy studies for a while now. It's very obvious with PET scanning. So that means that 30% of older adults are asymptomatic, but meet criteria for Alzheimer's disease. And we could even guess that there are people in here who meet criteria for Alzheimer's disease according to these new criteria, even though they're not manifesting any symptoms. So we have a lot of experimental evidence of the amyloid hypothesis. We can remove amyloid from the brain. We can treat amyloid with monoclonal antibodies, and we're very good at that. And every phase 3 study that has tried to do this has been successful somewhat in removing the amyloid, but it has absolutely no effect on clinical symptomatology, on dementia status, on anything. And in a press release, this was interesting that here in a study where they didn't require PET scans to meet criteria for the study, but they later went back and looked at the PET scans, about 30% of the people, 36% of the people who were included met clinical diagnostic criteria for AD but were amyloid negative. So now we have amyloid positive people who are asymptomatic. We have clinical dementia, Alzheimer's dementia folks who are amyloid negative. And the press release was this a technical error with PET, or was this a clinical misdiagnosis? So the field has embraced this amyloid hypothesis entirely, and rather than questioning the amyloid hypothesis, we put out press releases like, oh, the PET scans were wrong, or the diagnosticians don't know what they're doing. So this isn't the Biogen one. The Biogen just had a very exciting press release, which met all the criteria of exciting press releases. It was right before the big Alzheimer's meetings. It didn't have any data. It had a fuzzy outcome, lots of promises and excitement, and it was released primarily in financial magazines. And drove up their stock value. I don't know what shorting stocks is technically, but I don't know. I won't get into it. There was a recent study called the IDEAS study where Medicare actually reimbursed centers like ours to get amyloid PET scans on older adults who they diagnosed with Alzheimer's disease clinically. And about 50% of the patients diagnosed with MCI or AD were amyloid negative. Again, the press was that the results were shocking. Dementia experts, like places like Columbia, had misdiagnosed nearly half of their patients. No one is questioning whether there's what the relationship is between amyloid and dementia. It's just taken for fact. Of course, the problem is that we clinicians don't know what we're doing. As I mentioned, all phase 3 trials have failed, and tau-related changes are nonspecific markers of neuronal damage and frequently occur before the absence of beta amyloid. So the whole amyloid cascade hypothesis proposes that amyloid starts the whole thing, but we know that amyloid starts accumulating much earlier in life. And then, of course, we don't know, given someone's biomarker profile, what really the positive predictive value is or the negative predictive value is for that individual person, right? And so I can tell you if you have amyloid in your brain, but I can't tell you when exactly you're going to manifest symptoms. And what we know is that you might not. So 30% of people die with amyloid in their brain, but asymptomatic. And so the hardcore amyloid hypothesis folks say, well, if they lived long enough, they would have gotten Alzheimer's disease, dementia, which is, of course, an unfalsifiable hypothesis. Okay. And not to beat this horse too much, but if we think about diagnostic specificity and sensitivity, we know that about a third of individuals with clinical AD do not have biomarker evidence of AD. About a third of older adults with no symptoms have biomarker evidence of AD. And if clinical symptoms are the outcome, if we think about predicting who has dementia, then there's only about a 40% specificity and sensitivity of predicting who has dementia from the biomarker. Of course, the people who are very enthusiastic about biomarkers see it the other way. If biomarker pathology is the outcome, then symptoms are terrible at predicting the outcome, right? So our clinical neuropsychological tests, our clinical exams are really, really quite poor at categorizing people with or without biomarkers. So this, to me, is sort of the dilemma of the field, or one of the many dilemmas of the field. So does pure Alzheimer's disease actually exist? So let me break down these data. This is from our colleagues at Rush in Chicago. They have a huge study. This is Julie Schneider's data. And they followed people over many, many years and then classified them exquisitely at autopsy. And at the time of death, they're either classified as normal controls, non-cognitively impaired, mild cognitive impairment, or probable Alzheimer's disease. These are the clinical diagnostic schemes. And these different pie pieces are the different pathologies that they have: vascular disease, other pathology plus vascular disease, pure AD, which is plaques and tangles, AD plus vascular pathology, AD, other pathology, and vascular pathology. And so what you can see, as you move across the different diagnostic groups, the size of the pie chart that's pure AD gets smaller and smaller. So if you're dying with probable Alzheimer's disease, it's much, much more likely that you have AD pathology plus vascular disease. That's the vast majority of cases, and less likely if you're not impaired. And so to answer my own question, does pure Alzheimer's disease exist? Yes, it does, but only in people who don't have symptoms, right? So, so chew on that, right? So these and many other observations like these have motivated a lot of my questions about it. And particularly this part of the pie that includes the V, the vascular, is very, very intriguing to me because it's very, very rare to find someone who's diagnosed with AD who doesn't have any vascular pathology. And it's very rare, by the way, to diagnose anyone historically with vascular dementia who doesn't also have Alzheimer's pathology. And so when I joined Columbia, Richard Mayhew and colleagues were doing a lot of epidemiological work, and at the time, there's a focus on what are the risk factors for developing clinical AD epidemiologically. And so a lot of these came from here, and a lot of other big epi studies: diabetes, insulin resistance, high blood pressure, heart disease, high cholesterol, obesity, even ApoE, which we can think of as a vascular gene in some ways. All these things are risk factors for Alzheimer's disease, clinical Alzheimer's disease. And presumably, unless we're dualists, of course, that the increased risk for AD is due to some proximal damage in the brain, right? So all these risk factors probably cause some end organ damage in the brain that increase people's risk for AD. And in my world, the cumulative vascular burden, the exposure to all these vascular risk factors may put the brain's white matter at particular risk of injury. And so why might the white matter be particularly vulnerable? This, of course, is a brain without the brain parts. We often forget how much vascularization there is in the brain. The vascular supply is, of course, not uniform. And as the arteries penetrate from the gray matter into the white matter, the vessels become smaller and smaller. We have these watershed areas. And once they hit the white matter, you can see that they become quite tortuous, right? And so this is a typical older adult. And let me show you here. Here's the gray matter. As it enters into the white matter, you see all the tortuosity in the vessels. They really, really become quite vulnerable to hypoxic injury, to ischemia, et cetera. And these might have functional consequences, of course, because we know about the neurovascular unit that connects the vascular system with the nervous system. So as an imaging person, there are lots of ways of appreciating white matter change in the aging brain. And these are three standard sequences that you all are probably familiar with. We have the T1 anatomical scan, we have diffusion tensor imaging, and we have my favorite T2-weighted fluid attenuated inversion recovery scans. And there have been software packages that have been developed to analyze these different sequences to appreciate the bulk volumetry or the cortical thickness, or the subcortical white matter volume, tractography or the microstructure of the white matter with diffusion tensor imaging, and of course these white matter hyperintensities that we've been obsessed with. And so white matter hyperintensities are these areas of increased signal that we all should be a little bit familiar with in our older participants that seem to hug the walls of the lateral ventricles and extend deep into the deep white matter. And we've written software to quantitate the severity of white matter hyperintensities in 3 dimensions. We were just issued a patent this year on this software. And so what is the pathology? This is a subject of huge debate right now in the field. The reality is we're not sure. There hasn't been that great clinical pathological correlate study, but we know that all the risk factors for white matter hyperintensities in aging tend to be vascular, and that the autopsy series that have been done really implicate a role of ischemia, hypoxia, reduction of myelin, arterial sclerosis, all these different vascular type injuries in white matter hyperintensities. If they're restricted to the walls of the lateral ventricles, that's probably just the ependymal lining getting removed from the ventricles and some fluid getting trapped in there. But by and large, we think that these are markers of the severity of small vessel cerebrovascular disease. And so we've been asking various questions of our data, and these are the ones that are motivating me. Are white matter hyperintensities as a marker of small vessel disease a core feature of AD and involved in the pathogenesis or the clinical presentation of Alzheimer's disease? Do white matter hyperintensities interact with other biological markers of AD, and what are the factors that drive that interaction? And can we somehow leverage neuroimaging to inform our conceptualization, our pathogenic conceptualization of Alzheimer's disease, of course, with the ultimate goal of uncovering a new treatment or preventative strategies? And so we've been doing a lot of this work in that epidemiological study I alluded to before called the Washington Heights Inwood Columbia Aging Project, or YCAP. And over the years, we've scanned about 1,100 people. It's closer to 2,000 now. And I've overseen these different imaging cohorts. And our first pass this question was really just taking some basic MRI scans and quantitating the white matter hyperintensities using our software. And because Cliff Jack and others have really pushed the role, and Dev has a very nice early papers on the role of the entorhinal cortex as predictive of AD, we of course focus on the medial temporal lobe, which is where we think that a lot of at least the tau-related changes have occurred. All of our participants receive a comprehensive neuropsychological battery, and we classify them clinically as cognitively normal. Those with amnestic MCI, these are folks with mild cognitive impairment and memory impairment in particular. They're at particular risk for developing clinical Alzheimer's disease. Non-amnestic MCI, which we used to think are people who might be on course to another neurodegenerative disease, but might not be Alzheimer's disease, and these are often people we think of with vascular cognitive impairment. And then at the very beginning, we only scanned about 50 folks with Alzheimer's disease per se, clinical Alzheimer's disease. So our first question was very simple. Do these groups differ? Do the MCI groups differ in terms of the overall white matter hyperintensity burden? And what we found, surprisingly, was that those folks who are at greatest risk for developing AD clinically had the greatest amount of white matter hyperintensities, not the people who are on this non-amnestic course. When we look regionally, in the frontal, temporal, parietal, and occipital lobes, what we find is that there's a dissociation. First of all, you can appreciate that most of the white matter disease we see is in the frontal and the parietal lobes, and that there's a difference across groups. So let me unpack this for you. In the frontal lobe, individuals with AD, amnestic MCI, or non-amnestic MCI all have elevated, or as groups have elevated white matter hyperintensities. But in the parietal lobe, we see the specific relationship between amnestic MCI or AD diagnosis and increased white matter disease. So it seems to be a parietal lobe story. We've replicated this now in several different cohorts, and it's gotten a lot of attention in the pathology literature in particular. So of course, we're following these people longitudinally. We look at baseline and ask the question of whether baseline regional white matter hyperintensities predicts the risk of later development of Alzheimer's disease. And what we found was that it's specifically the parietal increases in the parietal lobe white matter hyperintensities that predicted incident Alzheimer's disease. And with all this in the model, hippocampal volume did not predict Alzheimer's disease diagnosis, did not predict incident Alzheimer's disease. So this runs counter to the Cliff Jack model that I showed you earlier, where you expect that the hippocampal volume to be a proximal marker of emerging clinical Alzheimer's disease. This is just the survival curves, and we can see people with a lot of white matter hyperintensity sort of fall off the cliff earlier than those with less white matter hyperintensities in the parietal lobe. So when we look longitudinally, this is work with Laura Zahodny, where we look at the change in white matter hyperintensities regionally and the change in diagnostic status over time. We find a very similar story, that again, it's the increasing white matter hyperintensity volume in the parietal lobe specifically that predicts incident Alzheimer's disease clinically. And when we look longitudinally, also the change in hippocampal volume does as well. So we've published a lot of different papers on this. It's been replicated, a lot of different cohorts, but there are a lot of haters out there, as I call them. And these are the types of criticisms that I tend to get at meetings, in grant reviews, and manuscripts that get rejected. So The first one is, Dr. Brickman, you're not actually studying people with Alzheimer's disease, you're studying people with mixed dementia. They're community-dwelling folks that have a lot of vascular disease, so it's not surprising that you're seeing vascular disease as a prominent predictive feature. Well, I would argue that that's Alzheimer's disease, that Alzheimer's disease doesn't occur really in the absence of vascular disease. And to understand it, we have to understand it in the context of other pathologies. Dr. Brickman, white matter hyperintensity and vascular disease are not related to amyloid, so it can't be part of the disease. And this gets at circularity and semantics. If you insist on diagnosing, characterizing it as the presence of amyloid only, then it becomes necessary for something to be related to amyloid to be part of the disease. Dr. Brickman, vascular disease is part of normal aging, but AD is not. You're conflating normal with disease. So I told you already that about 30% of older adults have Alzheimer's disease. Are they not normal? They look normal to all of us, clinicians. Dr. Brickman, you don't know the literature. I got this at a meeting. I'll tell you afterwards who said that to me. White matter hyperintensities are not a reflection of small vessel supravascular disease. And I think that yes, there's a lot of debate about that, and we need to do better pathological correlate studies, and we're working on that. And Dr. Brickman, not everyone with AD has a lot of white matter disease, and that's true, but I suspect that what's happening is white matter hyperintensities are really a tip of the iceberg that's shining a light on some fundamental vascular injury that's happening underneath. So to get at some of these issues, I turned to the Diane study, and if you're not familiar with the Diane study, it's really quite interesting. We're quasi-experimentalists as clinical researchers, observational scientists, so we can't randomly assign people to having Alzheimer's disease or not, obviously, but God can, right? We exploited that in this Diane study. This is a dominantly inherited Alzheimer's network. So everyone in the Diane study has a first-degree family member with an autosomal dominant, fully penetrant genetic form of Alzheimer's disease. And so they have a 50% chance of inheriting that gene, and if that gene is inherited, they have it has 100% penetrance. And so basically what happens if you get a bunch of siblings with a parent with a presenilin 1 or presenilin 2 mutation, and half of them are randomly assigned by virtue of how genetics works to the definite AD group, and half of them are randomly assigned to the not genetic AD group. And this model has delivered a lot. And so this was the big New England Journal paper a few years ago. Let me unpack it for you a little bit. On this line, on the x-axis, you have the years to the estimated years to clinical symptom onset, which is at 0. So if I'm 44, if I inherit a presenilin 1 mutation and my mom got the disease clinically at 50, then I'm 6 years away of getting the disease, right? So the parental age of onset is a very good predictor of the child age of onset. And so you could do this quasi-longitudinal modeling from cross-sectional data, and you can answer questions like, what are the changes, the biological changes that happen early on? I'll just point out a few examples. So here's A-beta deposition with PET scan in the precuneus, and you can see that about 20 years before symptom onset, you start to see this increase in A-beta deposition among mutation carriers, but not among their non-mutation controls. About, I forget what it was, 13 years before symptom onset, we start seeing tau increases in the CSF. And they picked probably the crappiest neuropsychological measure, but it fit the story very well, that when you look at logical memory function, that seems to change about 6 or 7 years before the clinical onset of the disease, right? And so that fits very nicely with the Cliff-Jack model. You have A-beta first, then you have CSF, and then finally you have the clinical symptoms. And so this is work with Sanju Lee, who is in your department, fabulously talented statistician. We took the Diane data and we quantitated white matter hyperintensities, and lo and behold, in these young, early onset AD cases, the mutation carriers had increased white matter hyperintensity volume reliably about 7 years prior to the onset of symptoms. And when we looked regionally, as we get more posterior in the brain, in the parietal lobes, the onset is about 7 years reliably, but you can see it's a very clear trend. And in the occipital lobes, a little bit more posterior than we see in our late onset cases, we see about 20 years or 22 years prior to onset of symptoms, do we see an increase in white matter hyperintensity volume among mutation carriers. So we felt that in this genetically pure, randomly assigned study of Alzheimer's disease, showing that there are at least white matter hyperintensities that are elevated reliably among mutation carriers really confirms that white matter hyperintensities are a core feature of Alzheimer's disease. We've replicated this finding not in an autosomal dominant, but in a very rich population of individuals in Dominican Republic who have 3 or 4 siblings with diagnosed Alzheimer's disease. And what we find in this cohort, whether you have no family history or a strong family history, you have elevated white matter hyperintensities in the parietal lobes and in the frontal lobes. So a little bit different from what we see here in the frontal lobe finding, but we certainly see this elevated parietal lobe story among people with and without family histories of AD. So again, in the more genetically pure forms of Alzheimer's disease seem to have this elevated white matter disease in posterior regions. So why might, if we believe that white matter hyperintensities are a marker of small vessel disease, we can ask, well, what is it that's linking vascular disease with Alzheimer's disease? Is it additive? Is it synergistic? Is there an interaction between the pathologies? Or is the relationship maybe epiphenomenological, that there's some other driver that causes you to have both Alzheimer's changes and vascular changes? And these, of course, aren't mutually exclusive, and these are the questions that we're trying to answer. Just going to skip this slide in the interest of time. So do white matter hyperintensities on Alzheimer's pathology interact? And this is work from Frank Provenzano, who used to be in my lab and now is a faculty member in neurology, where he asked the question, do we see increasing white matter hyperintensities in symptomatic and non-symptomatic amyloid positive individuals? So we turned to the ADNI, the Alzheimer's Disease Neuroimaging Initiative, and we downloaded all their T2-weighted MRI scans, and we quantitated their white matter hyperintensities. And we looked at the individuals who were amyloid positive based on their PET scan profile. So this is a PIB, Pittsburgh Compound B amyloid PET scan. This person is clearly negative. You see that it's green all along the cortex. There's a lot of nonspecific binding. And this person is clearly positive all the way up to the cortical, through the cortical ribbon. You see a lot of amyloid accumulation. So we characterize people as amyloid positive, but as I told you, a lot of people who are amyloid positive are asymptomatic. So when we compare the people who are asymptomatic, normal controls, to those people clinically diagnosed with AD, they all have amyloid. What differentiates them in our hands is the amount of white matter hyperintensities that they have. So it seems to be that there's a second hit, that there's this, at least in these data, and you could interpret this as you don't even need the amyloid, but we were cautious about that. But certainly the people who are manifesting symptoms seem to have a lot of small vessel disease. And when we look to see who is asymptomatic but later converts to clinical Alzheimer's disease, we find that individuals, both who are amyloid positive, have an increased risk for converting, but if you're both amyloid positive and have a high burden of white matter hyperintensities, you're at that much greater risk of developing clinical Alzheimer's disease down the road. So I think there's some sort of interaction between amyloid and vascular disease that seems to at least manifest clinically. But in most series, we don't see a very strong relationship between measures of amyloid pathology per se and measures of small vessel disease. Some people have reported it, we've reported it, but we don't typically see it. But I think that where my thinking is moving is this question of whether vascular disease is really inducing neurodegeneration itself, and that might or might not be independent of amyloid pathology, that there might be this other pathway where vascular disease causes neurodegeneration, possibly mediated by tau pathology itself. So we've just started to think about this in the lab, and it was motivated by some sort of random literature that I came across that hypoperfusion increases tau phosphorylation in mice. And in a mice form of tau that's similar to what we see in AD patients. So that was an interesting paper. Ischemia induces tau phosphorylation in the Mongolian gerbil. That's an interesting model. And it recovers after reperfusion. And so you can induce hypoperfusion. You can induce ischemia. It causes phosphorylation of tau, and then you can recover it. We also know that repetitive TBI induces traumatic brain injury induces white matter damage, which results in increases in total tau oligomers in mice. And recently, and this is where a lot of the controversy is, a lot of the debate in the field is, that we've noticed a relationship between hyperphosphorylated tau and white matter hyperintensities, particularly in the parietal lobe. And so the authors have gotten into great debates about this. The authors insist that what we're seeing is a Wallerian type degeneration, that tau neurodegeneration induces downstream white matter damage, and that's what we're picking up. And I think that it's the vascular disease that's inducing high tau hyperphosphorylation causing neurodegeneration. So we'll play that out, but we have some indirect evidence, I think, accumulating. So this is work from Batul Rizvi, who just left my lab, and she showed indirectly that white matter hyperintensities does, of course, predict cognition, but this seems to be mediated by cortical thinning or neurodegenerative changes that we see throughout cortex, and if you squint, it's sort of an Alzheimer's-like pattern. So we could hypothesize that this mediating pathway from white matter hyperintensities through cortical thinning to cognition is inducing some sort of an Alzheimer's-like degenerative change. We looked in ADNI more directly. This is work with Giuseppe Tosto, where we examined the effect of the predictive value of white matter hyperintensities at baseline to see the accumulation of CSF tau. And what we found, and this was again specific to the parietal lobe, that individuals with low parietal white matter hyperintensity didn't have that much accumulation of tau pathology in their CSF, but those with high amounts of white matter hyperintensities in the parietal lobe seemed to accumulate tau in their CSF at greater rates. And it didn't work vice versa. In other words, baseline tau didn't seem to predict accumulation of white matter hyperintensities. And this is work with Patrick Lau, who recently joined my lab, and Chuck Kreisel. And this is very, very preliminary in a handful of subjects, but we're starting to see now with tau PET imaging that if we correlate or we look for an association between the severity of white matter hyperintensities and the cortical accumulation of tau pathology, we see it throughout cortex, that there seems to be a relationship, at least in our hands, between white matter hyperintensities and tau pathology in older adults. And whether this is amyloid dependent or not, we need more numbers to figure out. And more definitively, with collaborators at SUNY Downstate, this is work that I'm doing with Frank Barone, we've come up with a transient MCA occlusion model of, I think of this as a white matter hyperintensity model. So what we do is we occlude the MCA, this is a mouse, so it's not a human, transiently, and if we do it for a long time, it induces a massive stroke. If you do it for a short time, it really induces sort of hypoperfusive injury in the mouse brain. And this to me is very exciting, is that first of all, you can see in this case we induced a stroke, that there's massive tau pathology in the mice who have an infarct versus those who do not have an infarct. So the ipsilateral side of the occlusion induces all this tau pathology, but not on the contralateral side. And what's also interesting is even though in this case, the stroke that it induces is up here in cortex, we see massive amounts of tau pathology in the hippocampus. And so this hyperperfusion model in wild-type mice is inducing tau pathology that's similar to what we see in Alzheimer's disease in humans. And so when we look at Alzheimer's mice, those are APP mice. These are mice that have a genetic mutation for developing amyloid pathology. If we induce hyperperfusion in the wild type, this is what I showed you before, they have increased tau pathology. if you don't induce hypoperfusion in the Alzheimer's mice, nothing happens. They don't get tau pathology. But if you give them hypoperfusion, they get tau pathology as well. So in these mice, even if they have the amyloid genetic mutation, they're developing tau pathology only in the context of hypoperfusion models. So we think this is very compelling. The first submission of the NIH grant, they didn't think it was as compelling as we thought, but the second round we'll nail it. Okay, so just in conclusion, we have current diagnostic models for AD that insufficiently account for the reality of the disease. I think cerebrovascular disease appears to be an important component of the AD syndrome, at least by driving the phenotype and the clinical expression. CVD and amyloid pathology interact in critical ways. CVD might be a second hint necessary for disease expression. CVD might be contributing to dementia through tau hyperphosphorylation and neurodegeneration. And I think that we can start to think about leveraging neuroimaging to understand individual differences in the disease and targeting vascular disease, or maybe what we're thinking now is inflammation, to treat or prevent AD. And both to illustrate how rough these ideas are and how much I ran out of time this morning, I mocked up this model where we think that, yeah, if you insist that amyloid causes tau and causes neurodegeneration and the clinical syndrome of AD, let's start entertaining that there are other pathways that might do this. There's vascular disease that might induce tau. It might be mediated by inflammation, activated microglia, and that this is a total independent pathway of inducing clinical Alzheimer's disease. So in this model, if you treat amyloid, it might not prevent the disease if there's this other active pathway inducing the disease. Some things that we need to resolve: how much of what we're seeing in the white matter is Wallerian degeneration? Is amyloid even necessary? Can we have an amyloid-independent path for the development of AD? And so this is where the field is. This is what I think the reality is, that Alzheimer's disease that we conceptualize, that we're all worried about, that has a public impact, is a multidimensional disease. There are a lot of pathologies. I'm talking about vascular disease, but there's TDP-43, there's Lewy body pathology, and in order for us to crack this nut, we really have to not think about these things as independent components, but think about how they coexist, why they coexist, and how can we target individuals differently depending on their biomarker profile. So where do we go from here? Of course, we're asking these questions. We want to talk about interactions more. When do white matter hyperintensities start? Can we develop a specific longitudinal processing stream for white matter hyperintensities? That's a technical challenge. We're going to do more mechanistic work. And of course, we're starting to really think about treatments. I'll skip that. And we're doing a lot of postmortem studies as well. Okay, so on that note, I'd like to thank current members of my lab. It's basically row 3 right here. A really talented group of people. Some people who've left recently who've gone on to do great things. I want to acknowledge my collaborators. Sanju Lee has been an absolute delight to work with on some of our important work. And Diane, some of these other names should be familiar to you. Our funding sources, and of course, this is our lab crest. In your brain, we will see, in your head, we will see brain, if you don't read Latin. Thank you very much for your time. Oh, Ted is leading the discussion.
I'm leading the discussion. So thank you, Adam, for a really fantastic talk. I mean, it was very illuminating. But we'll open it up to questions. I might start with one for you. So, you know, speaking for myself as a simple country psychiatrist, you know, seeing someone in clinic, they come in with, you know, pick your biomarker positive, say someone without a previous history of any psychiatric illness, now maybe with new onset major depressive disorder, positive amyloid, positive tau, you know, pick your biomarker.
Yeah.
What's the relationship? Do you think there's a relationship? Do we know what it is?
The relationship between
The fact that they are here to have amyloid or tau deposition in their brain and now have a new onset mood disorder.
Oh, mood disorder, right. So that's a great question. There's a lot of work on mood disorder, whether it's a risk factor, an early sign or symptom of some neurodegenerative cases. And I think I might be quoting this wrong. Laura Zahani's done some very nice epidemiological work where she does these lead-lag analyses, and it seems that depression is a risk factor for at least the clinical expression of AD. Whether it's an actual behavioral manifestation of the disease, I don't know. You have some thoughts about that? You're the psychiatrist. Yeah, I think it's a big question still.
David Forrest. At the end of June, they had this big article in the New York Times, study ties viruses lying dormant to Alzheimer's. This doctor at Dudley at Mount Sinai, and he believes that, and particularly herpes, had a lot of, so the idea is not that it causes Alzheimer, but that it triggers immune reactions. This sounds interesting in view of, that we have intensities in all in MS.
Immunological diseases,
and we have it also in, bipolar, and so, I mean, this seems to link everything all together. Or not.
The herpes story is interesting. We've seen this evolve. I'm involved with various different consortia that focus on big data, and this was, I think, probably the flashiest recent result of a big data type analysis where they just crunch through medical records of thousands and thousands of patients and seem to first identify that herpes and Alzheimer's disease clinically diagnosed in the hospital system co-localized on these giant, stem spoke graphs and everything. And so that was exciting. Whether it's real, we'll see, but I think that your point is well taken, that there's certainly lots of interest in immunology and inflammation in particular. A lot of the genetics studies are pointing to different factors that are implicated, TREM2, et cetera, in Alzheimer's disease. And I suspect that's sort of why I put the inflammatory mediating pathway, that inflammation probably ties a lot of this stuff together. And certainly what we're seeing in white matter signal might include some specific inflammatory component. It's a good point, thank you.
Yes, dazzling amount of data, absolutely a brilliant presentation. I have another question about treatment. And there's been some talk about glucose metabolism. I saw one of your slides had that. What part, if any, do you think glucose metabolism and the problems about insulin have to do with these things?
Yeah, so that's a good question too. So there's diabetes and insulin resistance, and it's certainly a risk factor for Alzheimer's disease. And I think that there are a number of hypotheses. Jose Luxinger and I have a grant on this topic specifically. So one is that diabetes is just a vascular risk factor. It's causing end organ damage in the brain, and you have Alzheimer's disease, you have some schmutz from vascular disease, and you look worse than otherwise. Another possibility is that diabetes targets the hippocampus specifically, and there are different glucocorticoid receptors in different subfields of the hippocampus, and it might be toxic to the hippocampus directly and induce the memory symptoms that we see in Alzheimer's disease, but maybe not through some of the pathways that we think of as Alzheimer's disease specific. And then the third possibility, of course, is that diabetes or insulin or whatever is inducing Alzheimer's pathology, plaques or tangles directly. And there's a little bit of evidence of amyloid, the relationship between amyloid and diabetes. We don't see that in our data, at least on our first glimpses. But now more and more, sort of along the lines of what I was talking about, there seems to be a link between diabetes and tau pathology. We don't know what mediates that, but that's starting to come out of some of the animal literature, and we'll follow that up with tau PET scans in our cohort.
Hi, thank you so much. That was really great. We're suspecting a multifactorial process, which, yeah, I tend to agree. Then why not consider alpha-synucleopathies? Most of our research is focused on tauopathies, but now we have DAT scans, and they're not being used very readily, and I was wondering what...
It's a good question. We think about alpha-synucleinopathies, if I said that right, in the context of Lewy body dementia. And so I think they are used. At our center, there hasn't been a huge focus on Lewy body disease. So it could just be what you're seeing locally. But you're absolutely right. I mean, I'm focusing on vascular disease, but we should be thinking about Lewy body and alpha-synucleinopathies, TDP-43. There are a number of pathologies that co-occur in the aging brain, and they all deserve their grand rounds presentation.
Can I ask a quick question, Adam? So, one thing we also know, amyloid in vessel walls, can be in vessel walls. What's the interrelationship between amyloid in vessel walls, cerebral amyloid angiopathy, and kind of what you're talking about?
Yeah, it's a great question. So I didn't present any of the data, but we've been measuring these cerebral microbleeds on susceptibility weighted images, which if you have them in the cortical areas, they tend to be, if you have two or more, they tend to be markers of cerebral amyloid angiopathy. And certainly individuals who are diagnosed clinically with CAA have a lot of fibrillar forms of amyloid as well. And individuals who have a lot of fibrillar amyloid, we see increased microbleeds that are markers of this more soluble form of amyloid in the vessel walls. What's been really interesting is I work with Nicole Schupf, and we have a Down syndrome study where individuals with Down syndrome all develop, or most of them develop Alzheimer's disease if they live long enough. They don't have a lot of vascular risk factors, so they don't have hypertension, and we see a lot of white matter disease, and we see we see a fair number of microbleeds. And so we think that amyloid, circulates through the vascular system and might be toxic as well. We have a couple papers where we show that the rate of cognitive decline is increased among people with radiological evidence of cerebral amyloid angiopathy, which is what Ted's talking about.
Sure. I want to join all the other people that have wanted to thank you for a marvelous
Thank you.
presentation.
Wow.
Rich and very thoughtful. And at the very least, people are going to take away from this some better understanding of why these questions are so complex.
Yeah.
But it used to be felt that these things would be resolvable more easily than some psychiatric conditions. And
Yeah.
clearly, that's not the case. I want to ask you a very low-level practical question. The differentiation between amnestic and non-amnestic MCI,
Yeah.
is that a fairly reliable, fairly standard thing that a good neuropsychologist can come up with?
Yeah, thank you for saying a good neuropsychologist. Yes, a good neuropsychologist can come up with that. So amnestic MCI, it's a very population-based answer to your question. So if you run a memory disorders clinic where people who are concerned about their memory and they're older, and they've read about Alzheimer's disease, and they've noticed some changes, come in, they don't have dementia, and we do a neuropsychological evaluation. We're very, very good at saying, you have mild cognitive impairment, and you're at really increased risk of developing clinical Alzheimer's disease in the future. If you go into the community and bring them into your clinic, not because they have complaints, but just if you do an epidemiological sampling, we can classify people as having MCI, but their risk of later developing Alzheimer's disease is about the same as their risk of later becoming normal. So that sort of indirectly answers your question about the reliability of the construct. And part of it is based on normative data, psychometric properties of our tests, the composition of community-based samples, the reliability of our instruments. And part of it is, I think we use these diagnostic cuts when we try to categorize people on a continuous construct. We try to put them in categories, and they're wobbling up and above and below these different diagnostic cuts that we put in. But I think we're really good at characterizing older adults' cognitive profiles. Whether we're really, really good at characterizing, getting people into a different diagnostic category itself, it's a little bit less reliable. Yeah.
Can you comment on any reversibility of these white matter
Yeah.
especially with exercise?
Yeah, it's a really, really good question. The reversibility of these white matter hyperintensities, I alluded to it, that we're really trying to do improve our longitudinal processing stream. at being technically difficult. And so, yes, when we quantitate white matter hyperintensity at one point in time, and then a second point in time, and take the difference of the volume, we see a distribution of change, and some of the distribution falls into the negative range, right? Whether that's measurement error, we're not sure. There's a lot that changes. Anyone who does MRI research, even on the same scanner with the same sequence, we see inhomogeneity biases. We see, even when the software is upgraded, you tweak one thing on the MRI scanner and our measurement changes a little bit. There have been a couple groups that have reported reverse of the white matter hyperintensities, and the interpretation is usually, as we were discussing before, some change in inflammatory response to something, but I don't think anyone's tied that to any behavioral aspect. When thinking about how to incorporate white matter hyperintensities into a clinical trial, what I'd probably do is stratify people by their white matter hyperintensity burden at baseline to see if that predicts outcome. Whether we would ever see reliably enough change in these lesions in a short period of time, I'm not sure. Thanks. Becky, yeah.
Yes, again, thank you for a great presentation, and I appreciate that you started off with Kraepelin, of course, who, throughout his Lair book in each iteration, championed an etiologically agnostic approach.
Yeah.
And then, of course, having Alzheimer next door, was able to come up with the original findings. And then, so the issue is that when you go in reverse order, especially with amyloid and with amyloid and tau, you spoke primarily of amnestic type typical Alzheimer's, but then, you also have posterior cortical atrophy, you have behavioral dysexecutive syndromes that look like FTD, you have logopenic syndromes that look like Mesulam's primary-progressive aphasia. So all of these where the primary neuropathology is amyloid plaque and neurofibrillary tangles. Have you looked at any of these other syndromes with this, with what you could ostensibly have as an endophenotype?
Yeah, I mean, it's a great question and a great point. We're amassing, certainly Ted has led tremendous efforts in FTD, some of whom, or many of whom, have logopenic forms. So we haven't looked yet, but it's a great suggestion. Posterior cortical atrophy is a little more rare, but we have a fair number of cases. Whether we can make a definitive statement about whether white matter hyperintensities track with the pathology, or whether it's, different. I'm not sure if we could get there yet, but it's a very good suggestion, very good idea.
Any other questions?
Others? Yeah.
Hi. I want to shift the focus back to the clinical if I can. I'm not
Sure.
sure you're going to be able to answer this question. But in terms of aging, what is the determination of what's normal in terms of cognition and cognitive function at age, say, 90, 100, 105?
That's an
versus
amazing...
what is pathological? I'm sort of working backwards. In the sense, like, what can we expect as being normal versus pathological for each age at the clinical level?
Right, so in terms of cognition.
Yeah, in terms of cognitive functioning, like, we know people's vision gets poor as they age, but we have different cures for that in terms of lenses. The hearing deteriorates, but we also have cures for that with hearing assistance. I guess we don't have anything in the cognitive area that helps someone that has cognitive disturbances to the extent of hearing or visual disturbances, but we can only judge by, what is normal, what's expected.
Right.
So
No,
what is your take on that?
It's a great question. We teach a course in our division called The Cognitive Neuroscience of Aging to the undergraduates, and when I lecture, that's the first question that I ask the students to get them talking. What's normal? What's normal cognitive aging? Or what's normative cognitive aging? And it's a great question. So how we do it neuropsychologically, you get big normative samples that represent the population. We test your memory. We've created some of our own cognitive tests here. We have normative data. And we look at the population distribution of performance on those tests. And we see which demographic factors relate to performance on a population basis. And then we do fancy regression equations and we say, okay, you got a 14 on this memory test. Someone of your age, your gender maybe, your educational background, the mean and standard deviation is 12 and 1, and so you're 2 standard deviations above the mean performance, and we would say that you're a super ager, right? I'm projecting what I think about you, but not implying that you're aging. We're all aging. But I think the idea is that that's how we've done it historically. That we've compared people's performance on tests to a normatively to a normed population study, and that has advantages and disadvantages. I think we're pretty good at saying on average what happens across a lifespan, and pretty good at saying compared to where we think you should be, you're either higher or lower. But you have to start thinking about, well, who was included in those normative samples, right? Did they have amyloid? Did they not have amyloid? Does that matter? Are they super healthy? Were they not healthy? Are they representative of the population? Does your demographic makeup match on to one of the cells that were included in the normative data? It gets very, very tricky. And so clinically, we nuance that because we're experienced with people of different backgrounds. We take into consideration lots of different lifestyle and life accomplishments when we do these normative assessments. But in a research context, that's what we typically do. We compare people's performance to a normative sample. I don't know if that answered your questions. I think the question about what's normal is a very, very salient one, because I could be doing a research study on people who are super agers. They have amazing cognition, and they're incredibly above the mean of what we expect them. So they can enroll in my super aging cognitive study, and they could simultaneously enroll in the Alzheimer's study because they're amyloid positive, because that's the inclusion criteria for the amyloid trials now. So someone can simultaneously be above normal and have Alzheimer's disease in today's conceptualization, right?
One can even extend that pathologically, right?
Yeah.
I mean, in other words, if you were saying 30% of aging people have, people have Alzheimer's disease, what is a normal pathologic state?
Right, right.
Other questions?
All right. Thanks so much, everyone. I really enjoyed
Thank you
this.
so much.